Today's content is IV management. You can find readings on this in chapter 22 and chapter 29 in your skills textbook. The pages are also listed in Canvas that you should review. Your learning objectives are to identify the equipment that is used for IV management, to describe gravity flow systems and both primary and secondary tubing and how to set those up, discuss the advantages and disadvantages of IV administration of drugs, explain the nurse's role in assessing, intervening, and reporting complications for IV management. And in lab, you will demonstrate the proper and safe preparation and administration of IV medications as well as IV fluids. IV management involves the parenteral route of medication administration. Last semester, you learned how to administer medications PO or by mouth. You also learned how to administer medications via a PEG tube or a gastrostomy tube. You learned about transdermal administration as well. But parenteral medication administration involves the administration of medications or fluids through body tissues and the circulatory system by way of injection. So we are injecting medications or fluids through the tissues into the circulatory system. Based on that, what are the 4 routes of parenteral medication administration? 3 of them you learned last semester. Hopefully you said subcutaneous or sub-Q, intramuscular or IM, intradermal or ID, and the last one that we will focus on is intravenous, which is IV. So what do you think some of the risk for in administering medications or fluids this way might be and why? Well, one of the risks would be infection. Because we are administering medications and fluids by injection, there is an impaired skin integrity, which puts a patient at risk for infection. That's why it's going to be so important to maintain aseptic technique whenever we are giving patients medications via this route. Another potential risk would be a risk of tissue damage. Again, we are injecting medications or fluids through tissue, so those tissues can be damaged in the process. Just think about how we kind of went over the importance of landmarking before you give in injections to make sure that tissues and nerves aren't damaged. And then when it comes to IVs, if we are trying to give a medication through the IV and the IV catheter comes out of the vein, there's a possibility that that medication or that fluid can go into the surrounding tissues and cause tissue damage. So those are kind of some things we want to be aware of. Other potential complications, and we'll go into more detail with this when we talk about IV pushes, when we talk about IV push or IV bolus, would be the potential for that. Well, the fact that when we give medications through an IV, the onset of action is very quick. So if there is an error, it is very difficult to correct that error because the medications act very quickly. So the patient will need to be monitored for adverse reactions after we are giving an IV push medication. Goals of intravenous therapy. We do it to maintain fluid and electrolyte balance or prevent fluid and electrolyte imbalances. It's used to administer medications, to replenish blood volume. We can give blood and blood products to patients to do that. Intravenous therapy is also used to provide parenteral nutrition in patients who are unable to intake adequate nutrition for their body needs, and that's something we'll cover next semester. And IV therapy can provide a route for hemodynamic monitoring and diagnostic testing. In order to provide patient-centered care, we must know our client. It's important to know their medical history. Why are they receiving IV fluids or IV medications? We need to know if they have a history of any medical disorders that might put them at increased risk for complications from the IV fluids or the medications. For example, do they have a history of cardiovascular disease or renal disease or cirrhosis that might put them at risk for fluid volume excess? What is the patient's psychosocial history? Do they have any history of anxiety that might make them especially nervous about receiving an IV or IV fluids? We need to know if there are any cultural or religious considerations to keep in mind. For example, if a patient has a saline lock and they are receiving heparin flushes to keep that line patent, we need to be aware of the fact that heparin is derived from animal products, so that might be a problem for certain religious or cultural groups. So again, that's something that we would want to keep in mind. Now, most of the time saline is used. Heparin's not used as much anymore, but you may see it from time to time. We also would want to be aware of the patient's lab results. Does the patient have an electrolyte imbalance that we need to watch and monitor for? We need to know if what the patient's allergies are. Do they have allergies to specific medications, to certain antibiotics, and they're going to be receiving antibiotics? Do they have allergies to adhesives or tape, which might be used to secure their IV, or any antiseptic solutions that we might use to sanitize the skin? All things we need to keep in mind. We also need to know the medications and solutions that are prescribed for the patients, how they work, what are the potential adverse reactions that might happen. We need to be aware of and know how to use the equipment. So we need to know how to use the IV pumps. We need to know about how to prime the tubing correctly. Certain tubing for different IV pumps can be primed different ways, so we need to be aware of that. And we need to know how to use the technology that's provided in some IV pumps. Now you will find a lot of IV pumps in hospitals that have advanced technology where they're called smart pumps, and they have these libraries of medications within them that will actually, it's for patient safety. You can select the medication that you're giving. For example, if you're giving an antibiotic, if you're giving Cipro, you could find Cipro in the library of the IV pump, and you would program in, when you programmed in the volume that you're going to give, or the milliliters per hour. If you programmed in too much, the pump will alert you. So it's important to be aware of that technology and how to use it. And if you don't know, make sure that you ask while you're in nursing school, you would ask your instructor, clinical instructor, or the nurse that you're working with. We would, of course, also want to monitor our patient to ensure that the intervention that we are providing is working and that it's not causing any adverse reactions. So we would monitor things like labs for electrolytes. We would monitor maybe daily weights in some patients, intake and output, and of course for complications. And then we would provide patient education, of course. We'd want to make sure that they understand any education that we're providing for them as well. So it's great to teach our patients, but we need to make sure that the patients actually understand what we are trying to teach them. Evidence-based practice guides the safe, efficient, and quality care that we want to provide to all of our patients. We don't simply do things just for the sake of doing it because that's the way we've always been doing it. We want to make sure that the interventions that we provide work. We want to make sure that they're safe, they're efficient, and they provide quality care for our patients. So research has shown that vascular access devices should be removed appropriately. And what that means is that If the patient has a complication, if you go into a patient's room and you assess their site, which is what you should do prior to starting IV fluids, and you note that there's redness or swelling or warmth around that site, that tells you that there's a possible phlebitis, so that IV needs to be removed. Additionally, when the infusion therapy has been discontinued, the doctor writes an order, discontinues the therapy, or when the IV site's no longer necessary for the patient's plan of care, we should remove it. Evidence also shows that disinfection caps that contain a sponge that's saturated with alcohol should be used on the end of needleless connectors. You will see this a lot when patients have central lines, because preventing central line associated bloodstream infections is very important. So these caps, and let's just refer to the image at the bottom of the screen of the patient's arm with the IV in. We refer to that as a saline lock. Well, at the end of that saline lock, you'll see a cap. There's like a white cap with some blue underneath. This is a needleless connector. And before you connect IV fluids or before you push a medication through that site, you will need to disinfect it with alcohol. Well, these caps, sometimes called Kuros caps, can be placed on the end of that needleless connector, and what it does is it will reduce the time that you need to disinfect. Or some facilities may say if you put a Kuros cap or disinfection cap on the end of that needleless connector, you may not need to disinfect it at all. It just depends on the policy of the facility. And these caps are great because they have been shown to decrease intralumen contamination. So that would decrease the rates of central line associated bloodstream infections, which is really important. And unfortunately, I don't have a picture of one to show you, but I could show you one when you come to lab. So those are sometimes used, those are recommended by evidence, especially with central lines. Now again, you may or may not see them with regular IVs, but definitely with central lines. Another recommendation is that primary and secondary continuous administration sets, or IV tubing, that is used to administer anything other than lipids or blood products, be changed no more than every 96 hours. So I also have an image on the screen on the far right side. You see some IV tubing. There's a primary bag and a secondary bag. So that tubing, as long as it's connected to the patient continuously and not removed, and it's not disconnected, that tubing does not need to be changed any more frequently than every 96 hours. Because if you think about it, every time you disconnect the patient from the tubing, there's a chance for infection when you reconnect. So as long as it stays on, it's not disconnected, it only needs to be changed every 96 hours. Infection control. We kind of alluded to that, and we'll keep talking about it because it's really important to prevent infection and use aseptic technique when we're dealing with anything really. But IV therapy is especially important because bloodstream infections can be very dangerous to our patients. So looking at this slide, what are some of the steps that the nurse is taking or can take when caring for a patient who is receiving IV therapy to prevent infection? So the first image that you see is of the nurse applying a Tegaderm, a special Tegaderm on top of the IV site. This is important because it will allow direct visualization of that site. So if there is any irritation, any signs and symptoms of redness, we can see that. Sometimes patients have to have a gauze dressing on because maybe there's some drainage there. It makes it really hard to see the site. So we'll have to change that every 24 hours so that we can visualize. But this is really important to have that, if we can, place that that tegaderm on top so that we can actually visualize the site, and it will alert us if there's any complications. The next picture, the next image is of a nurse washing their hands. Of course, this is the number one way that we can stop the spread of infection is by hand washing. The third image is of the nurse cleaning that needleless connector that we were just talking about with an alcohol wipe. Really important to clean that needleless connector before we are injecting anything into it or connecting any IV lines. It has to be sanitized. And then the last picture is of a nurse trying to recap the end of an IV tubing, and the method that is being used is the no-touch method. And this may be a case where the patient is receiving infusions or antibiotic, for instance, every 8 hours. So in between, they may not need to be connected so that they could walk around or just have a little bit mobility. We would still need to put a sterile cap on the end of that IV tubing if we're going to use it again. So again, that nurse is going to use a no-touch method. So if, for instance, when she or he is trying to put the cap on and it doesn't go directly in, it touches the side, then it's contaminated, so we wouldn't be able to use it. Safety guidelines. So in order to keep our patients safe, we want to make sure that when we are preparing any kinds of medication or we're preparing our fluids at the med cart and the med room, we are not distracted, we're being focused, we're being vigilant. And the Institute for Safe Medication Practices has recommended putting up signs for no interruption zones. So if you're there prepping your meds, no one should try to talk to you because you really need to focus and make sure that you're doing those checks to make sure that the patient is receiving what they're supposed to receive, at the correct time, the correct dose, the correct route, all of those things. So just to make sure that you're focused and you're not distracted, that will keep our patients safe. We are also verifying that the medication or the fluid has not expired prior to giving it to the patient, checking the integrity of it. There are no precipitates. It's the correct color that it should be before we're administering medications or fluids, because fluids are considered medications. We are, of course, doing those checks, those 3 checks. We're doing looking at the rights of medication administration to make sure that all of that's done. If you have a medication order that's not clear, we're seeking clarification from the provider on that. So, as nurses, we are like the final check before the medication or the fluid gets to the patient. So that's why it's so important to look up your medications to ensure that the dose that is ordered is actually the correct dose. It's not too much or it's not too little. Just think of yourself as that final check to keep your patient safe. Other safety guidelines is just to ensure that we are using technology correctly and we're not using workarounds. So if there's barcode scanning technology, is actually being used appropriately. I can remember as a nurse when many years ago when barcode scanning came out, I was working per diem at a hospital, and no one really wanted to use it because it was a couple extra steps, but it was to keep our patients safe, so it was necessary. But some of the nurses, instead of scanning the patient's armband, they would scan a barcode that they kind of kept on their little med cart. And it's like, no, that's not, you can't use workarounds. Everything is a little bit complicated at first when you start trying to learn how to use it, but that's why it's there. That's to keep our patients safe. So it's important not to use workarounds. It's important to just go the extra miles. Like I said, you are the last person that can prevent errors if there's any error with the ordering or the dosage for your patient. Strict aseptic technique has to be used with medication preparation, as I mentioned before, and we cannot delegate medication administration to NAPs. And this slide just kind of looks at barcode medication administration as well as labeling. So as I said before, we're scanning the patient, we're scanning the medication. There are also smart infusion pumps that have little libraries within them. So if you're and we'll talk about this a little bit later, it'll make more sense, but when you're programming in the volume of a IV medication or IV fluid that your patient should receive, if it's too much, if it's higher than what's recommended, then the pump has technology within it that will alert you that the dose is too high and that you should recheck it. Those are available, the smart pumps are available in a lot of facilities now. Labeling, very, very important. We have to make sure that the IVs are appropriately labeled, and I'll talk to you about how to label them. We want to make sure that our tubing is labeled, IV tubing, because it has to be changed at specific intervals. And if we are drawing up a medication in a syringe to administer IV push or IV bolus, we need to label that syringe as well before we leave the medication cart. Since you are going to learn how to hang IV fluids this week, it is important to take a closer look at IV solutions. There are many different types of IV solutions, but they all fall into one of three categories, either isotonic, hypotonic, or hypertonic. And you might have had some content on this last semester, so I'm going to go back and review a little bit so that you can understand what happens when these types of fluids are given. Let's go on to the next slide. It's important to review osmosis. So osmosis is just the movement of water through a semi-permeable membrane. And remember that water is going to move from the area of low solute concentration to the area of higher solute concentration. This is going to be important in knowing what happens in the body when different types of solutions are given to our patient. So again, osmosis is going to move from the area of, and you can kind of see from the image that's there, it will move from the area of low solute, low particles concentration to the area where there's more particles. And it's just to provide equilibrium. With that in mind, as I mentioned, there are three categories. There are isotonic solutions, there are hypotonic solutions, and there are hypertonic solutions. So going back to the fluid compartments in the body, we have the intracellular compartment, which is inside the cell, and we have the extracellular compartment outside of the cell, which includes the vessels, your blood vessels, as well as the space in between the cells. That's extracellular. So when it comes to our IV fluids, isotonic solutions are going to have the same osmolarity as our body fluids. So it has the same number of particles per 1 milliliter of solution as our body fluids. And that way, the water is not going to move anywhere because it's has the same number of particles. Everything's equalized. It stays there. So when we give IV fluids that are isotonic, though that volume is going to stay in the extracellular compartment. So it's going to stay in the blood vessels, okay, and outside of the cells. That's where it stays. So because of that, our patients might be we need to monitor them, especially our high-risk patients, for fluid volume overload. Those patients who are elderly, patients who have a history of cardiac disease, patients who have a history of renal disease, cirrhosis, we would monitor them for fluid volume overload. The fluid is the solution that we are administering is just going to stay in the extracellular compartment in the vessels. Now, with a hypotonic solution, hypotonic solutions have a lower osmolarity than our body fluids. And because of that, the water that is in hypotonic solutions is going to move from the blood vessels once we administer them into the intracellular compartment to try to equalize, to balance out. So the fluid again will shift, and you can see in the picture, it's like there's figure 17.07 on the screen. A shows the hypotonic solution, what happens. Again, because the solution that is being given has a lower osmolarity, there's less particles in the fluid than there is in the body fluids, and there's going to be a shift inside the cell. So you see the cell kind of swelling. This type of fluid may be useful. You may see it given in the case of diabetic ketoacidosis. I'm not sure if you've learned about this yet, but with diabetic ketoacidosis, patients can have a really severe osmotic diuresis because there's so much glucose in their bloodstream that's not able to get into the cells. It pulls water, and so patients can get really dehydrated. So we would give these fluids to rehydrate those cells that have been dehydrated. That's one case when you may see a hypotonic solution given. We have to be careful when patients receive this kind of fluid because it could lead to circulatory collapse if the patient's not monitored, because the fluid is going to shift inside the cell. It may deplete what's in the intravascular compartment. So again, it would be very important for patients to be monitored carefully. We would not want to give a hypotonic solution to what type of patient can you think of? Because it's going to cause, just think of it as, think of the effect that it has on the cell. When we look at the picture, the cells can swell, which if a cell is really dehydrated, that we want to rehydrate that cell, but we don't want it to get to the point of swelling and bursting. We would not want to give a hypotonic solution to a patient who has any type of cerebral swelling because those cells are already swollen, so we wouldn't want to give it to that type of patient. Our next type of solution would be the hypertonic solution, and you can see the illustration there in C, picture C in figure 17.17-07. With the hypertonic solution, there is a higher osmolarity in these solutions than there is in the body fluids. So what happens is that fluid is going to shift from the cells, from the body cells, from the intracellular space to the extracellular space to try to balance things out. So in C, you can see that the cell is actually shrinking because the fluid that's inside the cell is going outside the cell to try to balance out that higher osmolarity. These type of fluids can be very irritating to veins because they have such a higher osmolarity. Oftentimes they may be given only through a central line. These patients would also need to be monitored very carefully. They're probably in an ICU if they're receiving these type of fluids. Additionally, because if you think about it, if we're pulling water from the intracellular space, the fluid is going into the extracellular space, it's going in between the cells, it's going into the vascular compartment, that could put the patient at risk for fluid volume excess. So they may show signs and symptoms of pulmonary edema and heart failure if the heart can't handle that excess fluid. So these patients, again, are monitored very carefully, and we would and if you want to think about a case where a patient might receive a uh, hypertonic solution, it may be in the case of, again, a patient having some type of cerebral edema. Maybe they had a head injury and then there's some swelling in the cells in the brain. So we want to shrink those cells, remove that edema, so they may receive some type of hypertonic solution. So here we have a list of different IV solutions, common solutions, and they are categorized by their concentration, whether they are isotonic, hypotonic, or hypertonic. On this list, you can see that there are 3 solutions that are considered isotonic. You have 0.9% sodium chloride, which is referred to as normal saline. That's a common one that you'll give. There's lactated ringers. It's also considered isotonic, and the lactated ringers will have sodium chloride in it. It has sodium lactate, calcium chloride, potassium chloride in it as well. Then the other solution that's kind of considered isotonic is dextrose 5% in water. It's isotonic in nature, but when you actually give it, the dextrose that's within the solution is metabolized quite quickly by the body, and then it becomes more of a hypotonic solution. I didn't mention this, but the percentages that you see are actually the number of grams of the solute per 100 milliliters of fluid. And if something has potassium, it's measured in milliequivalents per liter. So we have the 3 isotonic solutions, and then our hypotonic solutions are listed there. And remember, those are our solutions that are going to cause fluid to move into the intracellular space. So you can look at those and you see, I would just kind of look at the percentages there. So for instance, isotonic solutions will look at normal saline, 0.9% normal saline. Well, the solutions that are considered hypotonic are less than that. So 0.33, 0.45. Those are hypotonic solutions. And then finally, our hypertonic solutions. There are some listed there. They have a higher percentage of solute than our normal saline. I just kind of use it as a guide to remember. More solutes than our body tissues, so they are going to cause water to move by osmosis outside of, from inside of the cell, from the intracellular compartment into the extracellular compartment. Okay, and those, again, they have a higher percentage than our normal saline. Normal saline is at 0.9%. Hypertonic solutions are like, just think of them when you look at them, they're like the ones that are the whole number. So dextrose, 10%, 50%, sodium, 3% to 5%. Okay, and then there's some combinations of dextrose and normal saline that are also considered hypotonic solutions. IV access. Kind of talked about this a little bit in our evidence-based practice slide, but before a patient is giving an infusion of any IV solutions or medications, we have to make sure that the IV site is patent. We have to make sure that the fluids are actually going in the vein, or the medications are actually going in the vein, which is where we want them to go. So we must check that site. You have to visually inspect. So you're looking above, around, below the site for any redness, any swelling, that would indicate that there's a complication, there's a infection, or that the IV may not, the IV catheter may no longer be in the vein. You also want to put on gloves first and then palpate, so actually touch around the site. And when you do this, you're feeling for warmth, you're feeling for swelling, and you're also asking the patient, does this hurt? Is this tender when I touch? Because it shouldn't be. And then the next step is to actually flush that site with normal saline. So you'll take in, usually you will have a pre-filled syringe of normal saline. Usually it's like a 10 milliliter syringe. And you're going to flush with 1 to 2 milliliters of saline. If it flushes without any resistance, then it's probably still in the vein. So we flush first and then we aspirate. We pull back on the plunger to see if there's any blood return. That's what's being shown in the first image. You can kind of see the blood that's in the line. That person is aspirating, they're pulling back. That gives us another indication that the catheter is still in the vein. Now, if the site flushes well but you don't get blood return, that doesn't necessarily mean that it's not in the vein. Sometimes if the patient has a smaller gauged IV catheter in, you won't get blood back. But as long as it flushes well, the patient doesn't have pain when you're flushing, and there's no swelling, then it's probably still in the vein, no big deal. And then we would end with a flush. Okay, so really important to make sure that IV is still working, it's still patent before we put anything in it. Safety, another safety thing that we should do is check in the provider order. The provider's order should contain the name of the IV solution to be given, the name of the medication if any is added. If the patient has a fluid and electrolyte imbalance, they might need some extra potassium, so they would write that. That would be in order as well. And then the volume to be administered and the time period during which the IV is to infuse. So for instance, they may be in order for normal saline. The provider would write 0.9% normal saline or just normal saline at 125 milliliters per hour continuous. Or they may write normal saline 0.9% 500 milliliter bolus now, or over an hour. Those are examples of what you might see. IV fluids can be given continuously around the clock without interruption, or they can be given intermittently at certain intervals. So continuous, or they may be referred to as primary infusions, are usually given to replace or maintain fluid and electrolyte balance. And these are given around the clock continuously until the provider changes the order. Intermittent IV infusions can be IV piggybacks, or they can be IV pushes. And again, these are given at specific intervals. For example, administering an antibiotic every 8 hours, or giving the patient a pain medication every 4 hours as needed. Those are considered intermittent. They are used, sometimes they are given through a saline lock, these intermittent infusions, or they can be given through a port in the IV line if a patient's already receiving continuous infusions. And I'll show you, we'll talk about how that's given. On this slide, there are two images. The first image is of a bag of IV fluids connected to the actual IV tubing. And the second image shows the IV ports that are on the bottom of the IV bag. So let's just start. Well, we'll start with the illustration to the far right that shows the ports. There are usually 2 ports on the bottom of the IV bag. There is the IV tubing port where you would insert the IV tubing, the spike of it. It's a short, and you'll see it when we get to lab, but it's a sharp spike that is inserted in a twisting motion into the IV tubing port. And then there's the medication port, and that's used when pharmacy adds any type of medication to the IV solution, medications or electrolytes. They're usually given through that medication port. Nurses don't typically add medications. That's usually done by pharmacy. So now we'll go back to the image on the left. Under the bag, you'll see you can see that the tubing has already been inserted into the bag via the insertion spike. Under that is we refer to that as the chamber. It can be, this one happens to be a macro drip chamber. We'll talk about that in further detail in a couple of slides. It could also be micro drip. So you can actually see the fluids coming from the bag down into the tubing by looking at this drip. And this drip is regulated by the IV pump, if you're using one of those, or we can regulate it by the roller clamp, which is located just below the micro drip chamber. This roller clamp can be moved up and down to increase the amount of drips that are coming down, or it can be decreased using that roller clamp manually. If we go further down, some IV tubings have special filters in them to filter out any particulate matter. Going a little further down, here is a port. Now, this tubing doesn't show it, but oftentimes there is a port, a primary port that's a little higher up on the tubing, and that port can be used to attach other infusions. For instance, it could be used to attach a piggyback of an antibiotic to the upper port. The second port that's located towards the end of the IV tubing is what we would use to administer an IV push or an IV bolus medication. In that case, we use the one that's closest to the patient. And then at the end of the tubing, you have well, this has a needle adapter. Most of them are needleless at this point with a protective cap on the end. So that end is what we would connect to the patient's actual saline lock. Regulating IV flow rate is skill 29-2 in your skills textbook. Accurate infusion rates is important when delivering solutions and medications. When the infusion rate is appropriate, it will reduce the complications of phlebitis, which is inflammation of the vessels, infiltration, which is when the IV catheter comes out of the blood vessel and goes out of the vein and goes into the tissues. Accurate flow rates can prevent fluid overload, the patient receiving too much fluid, and it can also prevent clotting of the vascular access devices. So those IVs can clot if they're not receiving enough fluids going through them to keep them patent. So we also need to keep in mind, what are some of those things if we set our IV pump correctly, or if we manually adjust our roller clamp so that the patient receives the number of drops per minute that they're supposed to, what are some of those outside factors that might influence the rate of infusion? And some of those things are, actually I don't think I have it listed there, but one of them is the height of the actual IV fluid bag. The height can affect it because it must be above the level of the heart in order to exert enough pressure for manual infusions. The higher the bag, because of gravity, the higher the bag, the faster the infusion. So it's recommended that you place your IV bag at least 30 inches above the patient's heart when you're that's how you would set your IV pole, and we'll practice that in lab as well. So the height of the bag influence infusion. when it's a manual infusion. Another thing would be changes in patient position. So if the patient is raising their arm up above their heart, if and with a manual infusion mostly, if they're kind of laying on that site, we want to be aware of that. If they're flexing the extremity that the IV site is located in, especially if that IV is in the wrist or if it's in the antecubital fossa, what could happen is that catheter, which is made of some plastic-like type material, it can bend, um, preventing the fluid from going in at all or really slowing it down. So if your patient has a IV site, again, in their wrist or the antecubital fossa, in an area where they can flex the extremity, you want to be really careful about that. You want to educate your patient not to bend those areas, or sometimes you might even have to put a special splint or board there to keep that extremity straight. Now, we typically don't want to put IVs in those locations, but to be honest with you, sometimes you don't have any choice. That might be where you find the best site. So just be aware of, if your IV is in those types of areas, there is a potential that it will affect the flow rate of the fluids. Other things might be spasms of the vein. So if it's a really traumatic IV insertion, or specific medications might cause the vein to actual spasm. And of course, if it's spasming, that's going to affect the flow rate. Any trauma to the vein as well. It can be trauma during insertion, or if the patient is inadvertently hits that area, it could cause trauma, and the inflammatory process happens, and that can affect the infusion rate. And of course, manipulation, sort of messing with the vascular access device. That's why it's going to be really important, and we'll talk about this with IV insertion, to make sure that that site is secure. So it's secured properly with the Tegaderm or some type of dressing and tape so that it doesn't move. Okay. Regulating IV flow rate happens through the electronic infusion device, EID, or the IV pump. And there's different types of pumps. I have some images on the screen. The pump that you see there is one that we actually have in the lab. It's the Alaris pump. We also have the Hospira pump that we will show you, and that's what's used, I think, at the John Muir Hospital. We have an older version, but it's very similar to what they use. So pumps are used to regulate flow rate, as well as manual devices. So our roller clamp. The image to the far left is an image of a roller clamp. The first one is when the clamp is in the down position. The second image is the clamp in the up position. So in the up position, it's actually open versus closed in the down position. The other device that you see, the image that you see in the middle of the screen with the numbers, it's blue and it starts at 30 and goes up to 100. That is it's considered a flow control device, or you may hear people refer to it as a dial of flow. It is set in milliliters per hour, so the numbers that you see are actual milliliters per hour. It is similar, but the accuracy of this type of device is similar to that of a roller clamp. I've only really seen this used in nursing homes and settings that are outside of the hospital that might not have a pump available. And you would need to double check that you have the correct flow rate by actually not just relying on the milliliters per hour that are listed there on the dial of flow. You would need to count the drops per minute as well, just to make sure that it's accurate, because again, it's about as accurate as a roller clamp, so you would need to double check that to make sure. Okay, and then the other image that you see to the right of that dial of flow is another type of flow control device. You may hear it referred to as a Volutrol. And what you can do with that is simply fill it with a specified volume, maybe 100 milliliters. If you want to ensure that your patient only receives a certain amount, you can put that into the chamber area, and then over that time period that you said, over an hour, for instance, that's all the patient would receive. The patient would be at less risk for fluid volume excess in this way, which is important in some patient populations, like our kids. You see, I use these a lot when I worked in pediatrics, so in some elderly patients as well. It may be important, especially if you don't. They may come to go with IV pumps, but especially if you don't have an IV pump, this would be something that would be good to use. Now we'll take a closer look at IV pumps and flow rate. IV pumps are programmed in milliliters of fluid per hour, and that's how the doctor, how the provider usually orders an IV fluid in milliliters per hour. So that's what you would put into your pump. If you take a closer look at the screen here, it says primary infusion, and then it has the rate. That would be the milliliters per hour. The doctor ordered normal, well, an example, it says normal saline 1,000 milliliters to infuse over 8 hours. The order is over 8 hours, but we need to calculate what that would be in milliliters per hour. So down here I have a formula for you. Milliliters per hour equals the total volume, which is 1,000 milliliters in our example, over the time in hours, which the order is for 8 hours. So 1,000 milliliters over 8 hours equals 125 milliliters per hour. So under rate, we would program in 125. And then over volume to be infused, the total volume that the patient is to receive would be 1,000 milliliters. Now we'll talk about manual infusions and flow rate. This is an IV infusion without an electronic pump. So perhaps you are in a setting where electronic pumps are not available, or the hospital is inundated and they're all being used at the time. Maybe there is a electrical outage and we can't use the pumps because there's no electricity, or perhaps you're in a facility that does not have electric pumps. So you need to know how to calculate a manual infusion so that your patients can receive any fluids that they may need, or any medications that they might need, antibiotics, for instance. And you calculate manual infusions in drops per minute. This is determined by the drop factor. That's actually the drop factor of the drip chamber that you see on the image, where there's a nurse who's there that has, you see her watch, and next to her watch there's the drip chamber. So drops come out of a little needle that's within the drip chamber, and that's what we count. Those drops can be either micro drip or macro drip. And you don't have to guess what it is. It's usually printed on the package, and I'll show you that on the next slide. But with the macro drip tubing, it will deliver 60 drops per milliliter. So these drops are, of course, smaller drops. They are used in infusions used with patient populations that we want to be very precise with. Maybe it's a medication that we really want to make sure that the patient receives exactly what they're supposed to. So think of pediatric populations, critical care patients, and the elderly. Macro drip tubing would be better in those types of situations. And then the macro drip tubing delivers their larger drops. So it could be either 10, 15, or 20 drops per 1 milliliter. And these are in cases where it's not as critical to be as accurate, because again, the drops are larger, And I'll just tell you now, what we'll do in lab is practice with macro drip tubing. This is what you see most often, what you would deal with most often. So that's what we will, that's what we will practice with. It's counting the drops on the macro drip tubing. This is an example of the packaging of IV tubing. There's two, there's A and B, and on the left we have A. This would be packaging from a tubing that contains 10 drops, that would deliver 10 drops per milliliter, and it says approximate because it is an estimate. So it would be considered macro drip tubing. And then on the right, B has, and you can see this on the top right, it has 60, and this is 60 drops per milliliter. That's what this tubing would deliver. And this would be considered micro drip tubing. And again, you never have to guess. You always want to, and this is really important when it comes to manual infusions, you always want to look at the packaging. It's printed there for you so that you are able to see how many drops per milliliter your tubing will deliver, which is going to be important in your calculation. You need to know that number. Now we are going to look at calculating the flow rate of a manual infusion. And to do this, we need to know three things. And we would get this from the order. We need to know the volume or the milliliters of fluid that is supposed to infuse. We would need to know the drip factor, which is located on the tubing packaging. Again, it can be 10, 15, 20, or 60. And then we need to know the time in minutes or hours. So the formula, well, actually, this is not a formula. This is dimensional analysis. I will show you a formula a little bit later. Well, actually, we'll go over formulas next week, but this week we'll just look at dimensional analysis. I think it's a little bit easier. You don't have to remember as much with dimensional analysis as you would if you're using a formula. So because we want to know drops per minute, we start out with that. And I'll just kind of go from the left side of the dimensional analysis here. So we're calculating drops per minute. So I have drops per minute equals, because I'm looking for drops, I have drops listed in the numerator, I'm going to start out and set up my problem with drops in the numerator of the problem. So drops per milliliter, and again, this is actually the drop factor. It's listed on the packaging. So 10, 15, or 20 times the milliliters per hour, which is what would be ordered by the provider. And because I need to know what my answer is in minutes, I would put the next thing that I would add would be 1 hour. I know that 1 hour equals 60 minutes. And with dimensional analysis, it's kind of neat because you will know that you set up your problem correctly if at the end you end up with drops per minute. So I can if I look back at my problem, I can cross out milliliters, I can cross out hours, and I'm truly left with milliliters per hour. Don't worry, I'll show you how to work this problem out. I'm putting together a calculations, a DDC video as well, and we will work out problems on that presentation. And our answer should be in whole numbers, because we can't do fractions of a drop. So when you're doing a calculation, actually you can see in the next example, we end up with 16.66. Well, it's impossible to count a fraction of a drop, so you would round that number. So in this example, we have a medication that is a total volume of 300 milliliters to be infused at 50 milliliters per hour using a macro drip tubing of 20 drops per ml. How many drops per minute is this? So I put, we're going to figure that out using dimensional analysis. So drops per minute equals my drop factor which is 20 drops per ml. I'm starting out with drops. That's what I'm looking for. And then I'm going to try to get rid of milliliters. So I look back at my problem. Where is milliliters? Well, that's in my infusion rate. So 50 milliliters per hour, I put that. And then because I want to end up with minutes, the next thing that I would add would be, I know that 1 hour is 60 minutes, and that way I could get rid of hours. And then I end up with 17 drops per minute. Again, we will do more of this. This is kind of just an introduction, so don't worry. So now we have started our infusion. We calculate the rate, started our infusion. What do we do if we notice that the solution is infusing faster than the prescribed rate, or it is infusing slower than what was prescribed? First of all, if it's infusing faster, we want to start thinking, wondering if our patient is at risk for fluid volume excess, because they are if it's going faster. So first thing that we do is slow the infusion. Then we want to assess our patient. We are looking for signs and symptoms of fluid volume excess. So what would that assessment look like? Hopefully you said you will get some vital signs. You will listen to the patient's lungs to see if they're still clear, or if you hear any crackles in their bases. You want to inspect and look to see if the patient's having any difficulty breathing. You want to ask them if they're having any difficulty breathing. You also want to note any urine output. You want to, and I should change the order of this, but you also want to, just some easy things that you could do without an order is put the patient in a high Fowler's position. This will allow the patient to have maximum lung expansion. Anticipate an order for oxygen if the patient is in fluid volume excess, and a diuretic. And then notify the healthcare provider. We always want to do a quick assessment before we notify the healthcare provider, so that we would have some information to give to them. If we notice that the solution is infusing slower than what is prescribed, we want to start assessing. We always begin the nursing process with assessment. So what's happening? Again, we know that the height of the IV fluids can affect the rate of the flow of the infusion. So we want to make sure that the IV fluids are at the appropriate height. We want to see if the vascular access device, or the IV, is positional, meaning if it's in an area of flexion that we talked about. Is it in the wrist, and the patient bent their wrist? Is it in the antecubital fossa, and maybe they bent that and kinked the catheter? So we want to look for things like that. We want to look for kinking of the actual IV tubing. Is a patient laying on the IV tubing? Is that why it's not flowing as it's supposed to? And we want to check for obstruction of the actual IV. So we check for obstruction at the site. First would be the tubing. Then we would check for obstruction at the site by flushing it. So we would get a pre-filled saline syringe, and we would try to flush it. And if it doesn't flush without any resistance, then if it doesn't flush without resistance, then there may be an obstruction going on. So it may need to be removed at that point. You would have to start another IV if it's obstructed. Delegation and collaboration. Regulating IV flow rate cannot be delegated to NAPs. The NAPs would let us know. We would tell them to let us know if the IV pump or EID alarms, if they notice that the fluid container is empty or nearing empty, or if the patient complains of any pain or discomfort at the IV site. If they have any issues, then we would tell the NAPs to let us know. Let us know if the patient needs to be disconnected from the tubing for any reason. We would be the ones to do that disconnection, because we want to watch out for, really have to be careful with aseptic technique. So we would be in charge of that. And just know that when it comes to IVs, delegation to LPNs, LVNs varies by nurse the State Nurse Practice Act. Here in California, in order for an LVN, LPN to hang IV fluids, and they can only hang certain IV fluids, they need to have the IV certification first. Okay, recording and reporting. We would want to record what type of solution the patient is receiving, the rate of the infusion in drops per minute or milliliters per hour, the integrity, it's clear, should be clear, if the IV is patent. And we would do that in the nurse's notes, or if there's a flow chart, we might do it there. Patient infusing normal saline at 125 milliliters per hour via IV pump. IV site no redness, swelling, tenderness, or pain. And then the patients, of course, document the patient's response to therapy, any unexpected outcomes, things that happened that we were not expecting. And then at the end of the shift, we would document how much was left or how much infused in our I's and O's so that they know, the next nurse knows. Teaching, we want to teach our patients about complications, things to report to us, pain, swelling, noticing any redness, noticing any leaking around the site. Teach them that if the IV pump alarms, that they should press their call light to let us know. Teach them about things that might affect the flow rate. So how they're moving to protect the site, not to raise the arm up too much, not to change the rate of the pump. In pediatrics, oftentimes you have to lock the pump so kids don't play with them because they get curious. Okay, with our pediatric patients, we want to make sure that you can't hang like 1,000 milliliter bag of IV fluids on a child. They just are not able to adjust to rapid changes in fluid if that were to happen by accident. So if a child is younger than 2 years of age, you don't want to hang any more than 100 milliliters of fluid at a time on that child. And this is where you may use those flow control devices, the Volutrol or the Buretrol, that has a little chamber that we talked about where you can only put a certain amount in. If your child is less than 5 years of age, no more than 200 milliliters of fluid hanging at a time. If they are less than 10, no more than 500. So you would only be able to hang a 500 milliliter bag of fluids. I didn't talk about this, but IV fluids, of course, they come in different volumes. So a standard volume for an adult would be a 1,000 milliliter bag. There's also a 500 milliliter bag. There's 250 milliliter bags of fluid as well. Special considerations with our gerontological population, we want to use a electronic infusion device, an IV pump, if at all possible, because they are at risk for fluid volume excess. So we want to make sure that their flow is regulated. If not, we want to use micro drip tubing so that what they're receiving is more precise, and keep an eye on it. Monitor them, vital signs, labs, urine output, weight. That all gives vital information as to how the patient is handling those extra fluids that they're receiving. And then with home care, we won't go into home care actually too much here. Just kind of go over that. Changing IV solutions is something that you may find yourself doing. It's something that the skill will show you in the lab how to actually change out a bag of IV fluids, and we would change the container if the provider writes a new order for a different type of solution. If the bag that is hanging is going at such a slow rate that it exceeds the hang time, and hang times are dictated by facility, you may only be able to hang an IV fluid over a certain period of time to prevent bacterial growth if it's going in too slowly. And you may change a container just depending on the patient's condition as that is needed. Typically, what we will do is if a patient is on continuous fluids, we would change out that new container, we'd hang a new container of IV fluids when there is about 50 milliliters left in the neck of the container. So it would be, if you look at the bag of fluids on the screen, sort of on the left side, there's a bag of lactated ringers. So if there's just fluid in the very bottom part of this bag, that's when we would hang it. So if we're using a pump, typically, if it's a 100 milliliter bag of fluids, we wouldn't program in the entire 1,000 milliliters. We would program in maybe 950 or 975 so that the pump would alert us before it completely empties out. And this is important because if the bag empties completely, that means that the tubing might empty, and then you will end up having to actually prime your tubing all over again, which is going to take more time and disconnections as well. Changing an IV solution cannot be delegated to an NAP. The nurse again would instruct the NAP to notify them if the pump is alarming, if they notice that the IV container is almost empty, or if the patient complains of any signs and symptoms of pain, swelling, burning, any drainage, or if they notice that the fluids look a little cloudy or just anything unusual with the fluids, then the NAP would alert the nurse. And again, remember that any LVNs or LPNs may be able to hang some IV solutions if they have the IV certification. Recording and reporting. We are recording the same information that we recorded when we hung the IV fluid initially, the rate, the type, the patency of the IV site, if we're using the IV pump or manual device, the patient response to therapy as well. And when the shift is over, we would document I's and O's. We'd let the next nurse know how much fluid infused and how much is left in the bag. Gives them an idea of how soon they need to get in to change it out. Special considerations, teaching our patients if we're giving them a new solution, if there's any additives inside that solution, not to touch the pump, to call us if it's alarming, not to change the rate. We would also, again, remind them of any change, like specific changes in their position that might affect the flow rate. And then again, home care, we're just going to kind of skip over that part. So changing the tubing is skill 29-4 in your textbook. You must adhere to strict infection control techniques, aseptic technique when it comes to changing the IV tubing. On the image that you see there, image B, this is a nurse inserting new tubing into the IV bag, and again, they have to make sure that that spike goes directly into the bag. If it goes on the outside, it's contaminated, we have to get rid of it. Remember that the solution, the IV fluids and medications are going to go into the patient's vein. We don't want our patients developing a bloodstream infection. So very, very important to maintain aseptic technique. Okay, so if your hands are a little bit shaky, and sometimes in the beginning they are, you just have to go really slow and take some deep breaths and make sure that that spike goes directly into the middle of the hole and you don't contaminate it. There are different types of administration sets. There is the primary administration set, and this is the main fluid that the patient is receiving. It also may have some type of add-on device. The image at the top of the screen, the green, that is a filter, so that's considered an add-on device. Extension tubing is also an example of an add-on device. There's also secondary administration sets is what we typically see with piggybacks. The tubing is a little bit shorter and it connects to the primary. whenever possible, you want to make sure that you are scheduling your tubing changes when you're changing out a new bag. It's a lot easier if you do it when it's time to hang a new bag and you know that it's the day to change the tubing. You bring in the new bag along with the new tubing at that time. It's just, again, a lot easier. So now we'll look at the recommendations for when to change IV tubing. If the tubing is a primary and or secondary continuous, meaning that the patient is not disconnected from the tubing, it's always connected to the patient, we would change that tubing every 96 hours, unless the patient's receiving lipids or blood products. We would also change that type of tubing whenever the vascular access device or the IV site is changed. Change the IV site, you change everything, tubing as well. Now, a thing to keep in mind is that if your secondary set, again, the secondary set is usually shorter tubing that's connected to the primary. If that is removed for any reason, it becomes an intermittent IV administration set. And if it's intermittent, it needs to be changed every 24 hours. Okay? And you see that. So secondary intermittent, primary intermittent. Those tubings are changed every 24 hours. These are IV tubing administration sets that don't remain connected to the patient at all times. These are sets that are connected maybe every 8 hours or every 6 hours, depending on how the medication is ordered for the patient. And again, one of the good things about the intermittent sets is that the patient can be a little bit more mobile if they have intermittent fluids versus having them infused continuously. We would also make sure that, for instance, okay, your patient's receiving antibiotic every 8 hours. The IV has infused. At the end of the infusion, when you disconnect your patient, you have to put a sterile covering device at the end of that tubing in order to use it within that 24-hour period. And when it comes to add-on devices, we want to minimize the use in add-on devices or filters. Sometimes you have to use a filter depending on what you're giving, or extension tubing. We want to minimize because if at all possible, because there is a potential for contamination when you're adding on things. There's also a potential for disconnection of those devices when you're adding on as well. Add-on devices have to be changed if the patient receives a new new VAD or a new IV site. It needs to be changed, or whenever the administration set is changed, as we mentioned before. So if patient is receiving a new IV site because the first one infiltrated or the patient developed phlebitis, we are going to have to change the add-on device as well. Or if we think that there has been some type of compromise to the integrity of the add-on device or the tubing for that matter, if there's leaking that's happening, we need to go ahead and change it as well. IV tubing changes cannot be delegated. Again, we will educate our NAPs to let us know if they notice any leaking from the tubing or around the tubing, or if they go into the patient's room and somehow the tubing is hanging on the floor, it's not connected to the patient, or that cap has come off the end, we would tell them to let us know so that we could change it. Skill 22-6 is administering IV medications by piggyback, intermittent infusions, and mini infusion pumps. So all of these methods are an intermittent type of infusion that usually goes through a primary IV line. These are methods to administer small volumes of fluid over a desired amount of time, and because we are administering them in conjunction with a primary fluid, we have to make sure that the two are compatible. So when you're looking up the medication, you're checking the compatibility of your primary fluid that is infusing, since there'll be some mixing. We have to make sure that they're compatible. The image that you see on the screen is of a piggyback or a secondary. Note that the primary infusion is going on the left side, and then on the right you have your piggyback or secondary bag. It is hanging a little bit higher than the primary because it will infuse first by gravity by being higher, and then the tubing for the piggyback or secondary is usually a shorter tubing, and it is inserted into the primary at the Y site that is higher. There's usually at least two Y sites, maybe more depending on the tubing, but you would connect the piggyback to the primary at the Y site that is closest to the drip chamber. Okay, and usually this is some type of antibiotic or medication that's, again, a smaller volume, so anywhere from 25 to 250 milliliters. It can be infused over, usually you can go up to an hour and a half depending on what you're infusing. But and we'll look at how to calculate those as well. So what happens when we administer the piggyback? Again, because the piggyback is higher than the primary, it is going to infuse first, and once the piggyback has finished infusing, then the primary bag will take over. This primary IV tubing has a back check valve in it that stops the flow of the primary fluid once the piggyback infusion starts to flow. Okay, and then it takes over once the piggyback is complete. We'll go over the steps of how to hang that in lab. On the left, this is an image of a mini infusion pump. It uses a syringe that pharmacy usually fills with a medication that the patient might need. I use these a lot when I work pediatrics, because of course they need smaller volumes. So again, medication comes from pharmacy in a syringe. You connect it to this special mini infusion pump, which is battery operated, and these syringes have their own special tubing that you would also use to administer the medication to the patient. And then on the far right is another illustration of the volume control administration set. Again, they can be referred to by the brand names of Volutrol, Buretrol, or Pediatrol. And you can see that this chamber attaches to the IV fluids just below the bag. And you see that there's also a roller clamp, so you can fill that chamber with a volume of anywhere from 50 to 100 milliliters of fluid. Then you would close the roller clamp so that no more fluid could go in, and then you know that over that hour or that specified time period that you set, the patient will only receive the volume that you put into that chamber. So it's a really good method of controlling how much your patient is receiving. Delegation and collaboration. Administering medications by piggyback, intermittent infusion sets, mini infusion pumps cannot be delegated to an NAP. Again, we are educating them to let us know if the patient has any complications, what are some of the common side effects of the medication that we're receiving that they would need to let us know about if the patient tells them instead of us. To let us know if the patient has any issues with their IV site, pain, redness, swelling, they notice any drainage, or if there's any change in the patient's condition or their vital signs. So we're just educating them to let us know if they notice anything unusual, if a patient complains of anything unusual. Recording and reporting. You would record on the MAR what the patient received. the medication, the dose, the route, infusion rate. You would record also this volume on an eyes and nose. And then we would, of course, be on the lookout for any adverse reactions and let the patient's provider know if the patient complains of any unusual side effects from the medication that they are receiving. So teaching, again, because we're giving medications, we're teaching the patient about what they're receiving, why they are receiving it, and what the adverse reaction, potential most common adverse side effects are to let us know about them. Pediatrics, again, close eye on their fluid and electrolyte balances, checking their eyes and nose. For any patient, you want to make sure that if your patient is receiving IV fluids, you know what the hospital's policy is on how often you are to round on that patient, how often you are to check the site, check the fluids. Usually, it's anywhere from an hour. You're actually putting eyes on that patient, an hour to 2 hours, but make sure that you know what the policy is, how often you should look at it. For our gerontological patients, we know that they're at increased risk for medication toxicity because oftentimes they are taking multiple medications. There's polypharmacy, and so there's a risk for medication toxicity because of the reactions between different medications. So be on the lookout for that. Know that they are at increased risk for fluid volume excess, so monitoring them carefully for signs and symptoms of fluid volume excess. And then home care, we'll kind of skip over that.